So we're always taught, right? In medicine, you trust the data. It's the golden rule. If the lab report says infection, you treat the infection.
You follow the evidence.
Exactly. But what do you do when the data is screaming one thing and the patient sitting right in front of you is telling a completely different and much scarier story?
Oh, that is the absolute classic conflict. It's the whole map versus the terrain problem. And if you keep following the map, when you can clearly see the terrain is a cliff edge, you're gonna fall.
You're gonna fall. And today's deep dive is, I think, a masterclass in that exact danger. We're looking at a tumor board case study that really pushes this idea of, what do you call it, diagnostic humility.
That's it.
We've got a 75-year-old man, a whole stack of radiology reports, pathology slides from Aga Khan University Hospital, and I mean, a clinical picture that is just a nightmare scenario.
It really is. And the mission for this deep dive, it's not just to look at some medical oddity. It's about trying to understand the decision-making process in oncology. How do you navigate that fog of war when your first tests are, well, wrong?
Not just wrong, but actively pointing you in the completely wrong direction.
Precisely.
Okay, so let's set the scene, because the source material has these clinical photos, and they are hard to forget. We have a 75-year-old man who walks in with a facial swelling on the left side.
Right.
It had been there for about 6 months, which, sounds kind of slow, but then in just the last 3 months, it just exploded.
And that acceleration, that right there is your first major clue. Benign things, cysts, chronic infections, they don't usually hit the turbo button like that. In oncology, velocity matters a lot.
And the size is just, it's staggering. The clinical notes say the mass is 15 by 10 centimeters. So for anyone listening, don't think golf ball. You should be thinking grapefruit.
A grapefruit on the side of his face.
Yeah, extending from his ear all the way down to his chin and then sideways into the neck muscle.
The sternothymostoid, yeah. And it's not just the size, it's the feel of it. The report describes it as hard, immobile, and non-tender.
There's a phrase in there that really stood out to me. The skin was non-pinchable.
Yes, that sounds like a tiny detail, but clinically that's incredibly sinister.
Why is that? What does that tell you?
Well, if you have a benign lump, say a cyst, it's usually encapsulated, it sits in its own little bag, you can pinch the skin over it. When the skin is non-pinchable, it means the mass has infiltrated the skin itself.
So it's not just pushing the skin out.
No, it's invading it. It's become one with the surrounding tissue, which is why it's also immobile. It's anchored in there.
Okay, so it's huge, it's hard, it's anchored, but his actual symptoms were surprisingly pretty mild at first. No trouble chewing, no fever, no earache.
And that lack of fever is another huge clue. It's a critical negative finding. If this was some massive raging abscess, which is what the test suggested, you'd expect a fever. Chills, he had none of that.
But he did have something else, and this is where it gets systemic. He was having syncopal attacks.
He was fainting.
And he had documented low blood pressure.
That's the red flag. That tells you this isn't just a local problem. Think about the anatomy of the neck. You've got this hard 15-centimeter mass right there. What else is in the neck?
The carotid artery.
And the carotid sinus, which is basically the body barometer for blood pressure. If you have a mass of that dense pressing on it, you can trigger a reflex that just tanks the heart rate and blood pressure. The tumor is physically hijacking his cardiovascular system.
Wow, so a massive infiltrating mass that's making him faint. The team knows this is bad. They start to work up. And this is where the story hits a major snag. They start with an ultrasound.
Standard first step, cheap, no radiation.
It shows a large, heterogeneous, solid lesion. Basically a mess inside. Then a CT scan confirms the parotid gland is enlarged, about 6 by 3 centimeters. But then the MRI comes in.
And the MRI gives you the real picture for soft tissue.
And the size just jumps. It's now 7 by 9 by 11 centimeters.
And look at that depth. 11 centimeters deep. This thing is digging down toward the base of his skull into his throat. In fact, the oral exam showed it was pushing his tonsil toward the middle of his throat.
So it was slowly choking him from the outside in.
Precisely. But here's the problem. Imaging tells you where it is and how big it is. It can't tell you what it is. For that, you need to get some tissue.
Enter the FNAC. Fine needle aspiration cytology.
And this is where the train goes off the rails.
They stick a needle in, suck out some cells, and they didn't just do it once, they did it 3 separate times.
3 times! And imagine being that doctor.
And all 3 results come back as granulomatous disease, chronic inflammation. One report even mentioned necrotic material. So the lab is telling the doctors, look, it's an infection, maybe TB.
The temptation to just put him on antibiotics or steroids and wait must have been immense. You have 3 separate pathology reports saying it's benign.
So why did the test fail so spectacularly? Was it just a bad sample?
It's not that the pathologist was wrong. They reported what they saw. The problem was the sampling itself. When a tumor grows that fast, it exploded in 3 months, it outgrows its own blood supply.
So the middle of it just dies.
The center becomes necrotic. It's a graveyard of dead cells and inflammation. So if you stick a fine needle into the middle of a 15-centimeter mass, you're probably just sucking up that necrotic gunk. You're aspirating the trash, not the living tumor cells on the periphery.
So that's the FNAC trap. You hit the physical bullseye, but miss the biological target.
Exactly. And relying on that would have been fatal. Because while you're treating an infection that isn't there, this high-grade lymphoma just keeps growing.
But the clinical team had that humility we mentioned. They looked at the patient, this hard, fixed mass, fainting, and they said, the map is wrong. They escalated to a true cut biopsy.
Which is a core biopsy. It's a bigger needle that slices out a solid cylinder of tissue. It preserves the architecture.
And that changed everything. The report comes back, flips the entire diagnosis on its head. It's not inflammation, it's high-grade B-cell lymphoma.
Specifically, diffuse large B-cell lymphoma, DLBCL. Now we have a completely different fight on our hands.
Right, an aggressive blood cancer. And the pathology report gives us the cheat codes on how to fight it.
The immunohistochemistry, yeah.
Let's break that down. There's enough that's souvenir.
Yeah.
First up, CD20 positive. Why is that so important?
That is the single most critical finding for his treatment. CD20 is a protein on the surface of these cancerous B cells. It identifies the enemy. And because it's positive, we can use a targeted therapy, rituximab, that acts like a homing missile for that specific protein.
So if we're CD20 negative,
our best weapon would be off the table.
Got it. Then there's this number, Chi-67 index. It's at 80%. I know that measures how fast cells are dividing, but 80% sounds astronomical.
It is. It's terrifyingly high. A low-grade lymphoma might be 10, maybe 20%. Chi-67 is the cancer speedometer. 80% means that at any given moment, 80% of those tumor cells are actively dividing.
That explains the 3-month explosion.
It does. It confirms this is high grade. But there's a paradox here. High grade tumors, because they divide so fast, are often more sensitive to chemotherapy.
Right, because chemo targets dividing cells.
Exactly. A slow, lazy tumor can sometimes hide from the chemo. A tumor running at this speed basically sucks up the poison.
Okay, so the diagnosis is DLBCL. We have a target, CD20. Now for the battle plan. You get this giant lump on his face, the intuitive reaction is cut it out. But the tumor board said absolutely not.
And this is so crucial. Lymphoma is a systemic disease, a disease of the immune system. That lump on his face is just the local office of a national problem. The headquarters are everywhere.
Cancer cells are already circulating in his blood and lymph system.
Almost certainly. So if you do this massive disfiguring surgery on a frail 75-year-old, you risk paralyzing his face, and you still haven't cured the disease. You've just removed the most visible symptom.
It's like picking a weed's flower but leaving the roots.
That's a perfect analogy. So the scalpel is out, chemical warfare is in, the protocol is RCHOP.
The gold standard. Let's unpack that. What are we actually putting into his body?
It's a cocktail. It attacks the cancer from multiple angles. We already mentioned the rituximab, the immunotherapy homing missile.
Then C, cyclophosphamide.
That's an alkylating agent. It literally damages the cancer's DNA so it can't replicate.
H is for hydroxydonorubicin.
Also known as doxorubicin, or the red devil.
Because it's literally red.
Literally red in the IV bag. It's an incredibly potent drug that messes with DNA replication, but it comes with a heavy price. We'll get to that.
Okay. O is for uncovin or vincristine.
Vincristine stops the cells from physically pulling apart during division. It freezes them mid-act.
And finally, B for prednisolone. That's just a steroid, isn't it?
Just a steroid. In lymphomas, high-dose steroids are a weapon. They actually trigger cell suicide in lymphocytes. It's a key part of the cocktail.
So we have this 5-drug plan, but we have to remember the patient. He's 75, he's fainting. The tumor board had to assess his ECOG performance status. How do you decide if he can even survive the cure?
It's a constant risk-benefit calculation. The notes mention considering Armini-CHOP, which is a dose-reduced version. You dial back the intensity to spare the patient, and you just pray you're still hitting the cancer hard enough.
And the biggest risk seems to be his heart. You mentioned doxorubicin, the red devil.
Yeah, it's notoriously cardiotoxic. It can permanently weaken the heart muscle. And since our patient is already fainting and has low blood pressure, his heart is already suspect.
So first they have to do a 2D echo to check his heart's pumping power. If it's too low, they can't even use it.
Right, and that's the tightrope. The most powerful drugs are often the most toxic, and you have to decide if the patient can take the hit.
There's one other complication listed that just sounds terrifying. Tumor lysis syndrome.
Yes, that's a true medical emergency.
What's happening there?
It goes back to the sheer size of the tumor burden. We've got a 15-centimeter mass with billions of cancer cells, and we're about to hit them with a cocktail that kills them very, very quickly.
So you start the chemo and billions of cells just die at once.
They burst open, and they dump all their contents, potassium, uric acid, phosphorus into the bloodstream all at once. It's a biological toxic spill.
And that can kill you.
Absolutely. The sudden spike in potassium can stop the heart. The uric acid can crystallize in the kidneys and cause acute renal failure. You can cure the cancer, but kill the patient with the cure in the first 48 hours.
That's incredible. The treatment is so effective, it's dangerous. So how do they prevent it?
Massive hydration. You flush the system, and you use drugs like allopurinol or resveratrol to break down the uric acid before it can damage the kidneys. He'd need to be admitted, likely to a high dependency unit, just to manage that risk.
And we haven't even talked about staging. We know it's in his neck, but is it only in his neck?
That's the next step. A PT-CT scan and a bone marrow biopsy. They have to know if the factory, the bone marrow, has been taken over. If it has, he's automatically stage 4.
Which changes everything.
It changes the prognosis and might mean they have to be even more aggressive despite his age.
It's stepping back for a second. This whole case started with a man who could have so easily been sent home with antibiotics.
And he would be dead, without question. If they had followed that initial map, he would be dead.
It just highlights what you said at the start, that diagnostic humility. It's not about lacking confidence. It's about being confident enough to question your own tools.
That's it exactly. The doctor saw a malignant-looking patient, and they refused to accept a benign-looking diagnosis on a piece of paper. They trusted their eyes.
And getting that true cut biopsy, that single decision, bought this man a chance.
It moved him from an unsolvable mystery to a treatable, though very difficult, oncology case.
I want to leave our listeners with one final thought. We talked about the fainting, the syncope, and we're framing it as a frailty issue, maybe a cardiac problem. But what if it's simpler?
The mechanical pressure.
Right. If the tumor is physically pressing on the carotid sinus and causing the fainting, what happens when the RCHOP starts working?
The tumor will shrink. And with DLBCL, it can melt away incredibly fast.
And as it shrinks, the pressure comes off.
So the treatment that you're worried will damage his heart might actually be the very thing that saves his heart function by restoring his blood pressure regulation.
It's a fascinating feedback loop. You have to risk the heart to save the heart.
A perfect summary of oncology, really. It reminds you that nothing in the body happens in isolation. It's all connected. The mass, the blood, the pressure, the cells.
Which is why you need a tumor board. It takes a whole team to see the whole picture.
Absolutely.
Well, thank you so much for walking us through this one. It's complex, it's a little scary, but it's incredibly important.
My pleasure. Stay suspicious of the easy answer.
Until our next deep dive, stay curious.